Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul uqdatam min lisani yafqahu qawli. Allahumma inni as'aluka ilman nafi'an rizqan tayyiban wa amalan mutaqabbala shifa min kulli da. Today the topic of discussion is the ovarian tumors. I will discuss the ovarian tumors in part 1 and part 2. Part 1 I will discuss the benign ovarian tumors, and in part 2 I will discuss the carcinoma of the ovaries. Now, you can see in this picture that is in one side the ovarian cyst and on the other side is the ovary, which is normal. And this ovarian cyst is like a water ball like appearance, and you can see the difference between the two. What is an ovarian cyst? It is a fluid-filled sac that forms on the ovary. Ovary with cyst you can see in this picture on this side, and this is the normal ovary again. Benign ovarian tumors comprise about 85% of all the ovarian neoplasms. Premenopausal women more than 90% benign, just 60% benign in postmenopausal women. Types of the ovarian tumors you can see: the functional and inflammatory, benign tumors and cysts, malignant, and or the malignant potential. Functional in that is the follicle cyst, corpus luteum cyst, theca lutein cyst. Inflammatory, that is tubo-ovarian abscesses, and benign tumors or cyst, endometriotic cyst, Brenner tumor, benign teratoma, dermoid cyst, and fibroma. Rare or very rare potential for the malignancy. Malignant or the malignant potential, we see malignant teratoma, endometrioid carcinoma, dysgerminoma, secondary ovarian tumor, cystadenoma, cystadenocarcinoma, more than 50% for serous, 5% for mucinous, granulosa cell tumor, 15 to 20%, and erhinoblastoma, that is less than 20%, and theca cell tumor, that is less than 1%. Types of benign ovarian tumor. We have the number 1 in the functional, follicular cyst, corpus luteal cyst, theca luteal cyst, inflammatory, tubo-ovarian abscess, and endometrioma. Germ cell, that is benign mature teratoma, epithelial, serous cyst adenoma, mucinous cyst adenoma, Brenner tumor, sex cord stromal tumor, that is the fibroma and thecoma. Surgical cyst in we see here, that is the paratubal cyst, endometrioma, the chocolate cyst, dermoid cyst, and here is the large serous cyst. Ovarian cyst in the normal ovary, and then the ovary with the cyst you can see. Dermoid cyst, which contains the layers of all the mesenchymal layer, that is the parts of all the 3 types: endometrium, ectoderm, mesoderm, and endoderm, mesoderm, and ectoderm. The 3 germ-like types of layers. The contents you will get this. And enlarged follicle, there's a functional cyst, and then is the blood in the cyst and ovarian capsules, and then you can see the cyst here. Clinical presentation: asymptomatic and acute lower abdominal pain mostly represents the torsion, hemorrhage, or the cyst rupture. Chronic lower abdominal pain, that is dull ache, abdominal mass, abdominal distension, pressure symptoms, that is urinary or the bowel, and irregular vaginal bleeding. Here, warning signs of the ovarian cyst you can see that the woman should not ignore: pelvic pain, painful intercourse, dyspareunia, pain during bowel movements, vaginal bleeding or bloody discharge, breast tenderness, and frequent or urgent need to urinate, stomach bloating, and nausea or vomiting. Investigations. All the baseline investigations: white cells count if the tubo-ovarian abscess is suspected, and mostly diagnosed on abdominal or transvaginal ultrasound. That is CT or MRI done to differentiate the benign and malignant tumors. Tumor markers further help you determine the risk of malignancy. Tumor markers: CA125 epithelial ovarian tumor, serous borderline ovarian tumor, alpha fetoprotein germ cell tumors, immature teratoma, endodermal yolk sac, beta ACG germ cell tumors, dysgerminoma, inhibin, sex cord stromal tumor, granulosa cell tumor. Risk of malignancy index, that is RMI, classifies patient as being low or high risk for malignant disease. RMI is a product of ultrasound score, menopausal status, and CA125 level, international unit per milliliter. RMI is equal to U into M into CA125. Ultrasound is scored in point 1 point for each of the following characteristics. Multilocular cyst, you solid. Metastasis, ascites, bilateral lesions. U is equal to 0 for ultrasound score of 0. U is equal to 1 for ultrasound score of 1. And U is equal to 3 for ultrasound score of 2 to 5. The menopausal status is scored as number 1, premenopausal, and 3 is equal to postmenopausal, no period for more than 1 year, or a woman over 50 who has had a hysterectomy. Serum CA125 is measured in international unit per mil. Risk of malignancy index RMI. If a cutoff value of the 200 is used to discriminate benign from the malignant ovarian masses, there is a good correlation with the sensitivity of 87% and specificity of 97%. Risk of malignancy RMI, low, moderate, and high. That is less than 25 and less than 3, that is risk of cancer in percentage. Moderate 25 to 250 and risk of cancer is 20. High, it is more than 250 and risk of cancer is 75. Ultrasound findings to differentiate between the benign and malignant cyst, as you can see in B1 locular, and here it is the cyst. Presence of the solid components with a large diameter of less than 7 cm, B2, B3 presence of the acoustic shadow here, and then B4 smooth multilocular tumor with large diameter less than 100 mm, B5 no blood flow, that is color score 1. Here M, irregular solid tumor, M2 presence of ascites, M3 at least 4 papillary structures, M4 irregular multilocular solid tumor with largest diameter more than 100 mm, M5 very strong blood flow, that is color score is 4, you can see. Non-neoplastic functional, follicular cyst normally less than 3 cm. Corpus luteal cyst normally less than 5 cm may show signs of hemorrhage into cyst or cause hemoperitoneum. Pathological. Ovarian endometriotic cyst filled with old altered blood chocolate cyst. Polycystic ovarian syndrome, generally bulky ovaries with multiple small follicles, fibrotic capsule and smooth surface ring of Pearl sign on TU, transvaginal ultrasound. Theca lutein cysts. Multiple ovarian cysts occur in conditions with increased ACG. For example, highlighted to form molar pregnancy, resolve if ACG level falls. Ovarian edema. Secondary to ovarian torsion, the ovaries enlarged and boggy. Exclude germ cell tumor in young women. Benign neoplasia. Epithelial tumors, that is a serous and cyst adenoma. You can see. Usually unilocular, with a serous cyst adenoma, and 20 to 30% are bilateral, may have septations. Serous cyst adenoma, you can see. Gross appearance. Mucinous cyst adenoma, often multiloculated, but usually unilateral, that is 5% bilateral. Can get extremely large, more than 150 kg. This is benign Brenner tumor, and you can see mucinous cyst adenoma. Brenner tumor. 1 to 2% of the ovarian tumors unilateral and have solid gray, white, or yellow appearance to cut surface, fibrous elements, and transitional epithelium. Benign germ cell tumors, mature teratoma or dermoid. 10% are bilateral, 90% occur in the women of reproductive age. Usually full of sebaceous material and hair, but may contain teeth, skin, cartilage, fat, or bone. Can cause chemical peritonitis if contains spills. Sex cord stromal tumor. Fibroma, commonest stromal tumor, up to 40% present with Meeks syndrome, ascites, and pyruvafin. Circular lytic cell tumor, 1% of the ovarian tumor, produce androgens and present with virilization. Thecoma. Produce estrogens, present with abnormal vaginal bleeding and lipoma. These are the sex cord stromal tumor. Management. Cyst presenting acutely with lower abdominal pain without signs of peritonism or systemic upset. Manage conservatively with analgesia. Most will usually spontaneously resolve. Presentation with an acute abdomen and or signs of systemic upset due to ovarian torsion rupture, or hemorrhage of a cyst equal to or more than urgent, diagnostic laparoscopy or laparotomy may be required. In these cases, blood should be sent for tumor markers at the time of surgery, as if cyst is not benign, this will aid follow-up. In perimenopausal women, malignant tumors rare in this group, it is very rare in this group, it's 0.4 to 9 into 100,000. Aim to exclude the malignancy and preserve fertility. Rescan in 6 weeks. If cyst is persistent, then monitor with ultrasound and CA125, for example, 3 and 6 months, 50% less than 5 centimeter will resolve less with larger cyst and calculate RMI. Management of the low risk cyst. Transvaginal cyst aspiration under ultrasound guidance has no advantage over expectant management. If cyst still persists or is more than 5 centimeter, then consider laparoscopic cystectomy. If cyst more than 5 centimeter or is a dermoid, aim to prevent spillage of contents. If suspicious findings at laparoscopy, abundant procedure, take peritoneal biopsy for diagnosis. More or is equal or more than refer to cancer center for full staging laparotomy. In postmenopausal women, low RMI less than 25, simple less than 5 centimeter cyst and normal, CA125, follow for 1 year with ultrasound and CA125 every 4 months. If no change, then discontinue monitoring. If change and RMI still low or women request removal, laparoscopic oophorectomy ULE bilateral is appropriate. Moderate RMI 25 to 250, oophorectomy ULE bilateral in cancer center recommended. If malignancy found, then full staging laparotomy will be needed. High RMI, that is more than 250, refer to a cancer center for a full staging laparotomy. Now, differential diagnosis for pelvic and abdominal mass, that is gynecologically. Pregnancy related, you can see this is a normal intrauterine pregnancy, old ruptured extrauterine pregnancy, that is abdominal tubal pregnancy, molar pregnancy. Uterine origin, uterine fibroids, advanced uterine carcinoma or sarcoma, hematometra or pyometra. Then tubal origin, hydro or pyosylpings, tubo-ovarian abscesses, advanced cancer of the tube. Ovarian origin, ovarian torsion, benign cyst, endometrioma, benign tumor, dermoid, fibroid cyst adenoma, borderline tumor, malignant tumor, that is carcinoma, granulosa cell or germ cell tumor. Differential diagnosis for the pelvic or the abdominal mass and surgical, appendicular abscess, obstructed hernia, interception, colorectal carcinoma, subacute intestinal obstruction, diverticular abscess, large bowel tumor, mesenteric tumor, abdominal aortic aneurysm, renal tumor, pelvic kidney, bladder carcinoma, urinary retention. Now, up to here, I will stop this discussion of the benign ovarian tumor, and with that, thank you, Jazakallah. Hope it will freshen your knowledge.